This is one endothelium, blood vessel lining. This is endothelium. Endothelium is the richest source of von Willebrand factor. Number 1 MCQ. Endothelium is the richest source of von Willebrand factor. So von Willebrand factor is maximum inside endothelium. So von Willebrand factor is maximum inside endothelium. PGI exam, von Willebrand factor is synthesized by endothelium, megakaryocyte, liver. What do you choose? PGI exam. Remember, all are right answer. Many of the guys they are writing liver is not synthesizing. Absolutely wrong concept. It's a line of intro. Von Willebrand factor can be synthesized by endothelium, which is a maximum synthesis. Apart from this, they can be synthesized by megakaryocyte and from liver also. So this is right answer. This von Willebrand factor, when they are synthesized inside a endothelium, they are stored inside a body. What is name of this body? Another MCQ. What is name of this body? This body is called as Weber palate body. So this body is known as Weber palate bodies. So Weber palate body, another MCQ. Question was, Weber palate bodies are seen in RBC, WBC, platelet or endothelium. So what is your answer now? Answer is endothelium. So remember, Weber palate bodies are present inside endothelium for the storage of von Willebrand factor. So this is some important information. So here just want to convey you one thing, that von Willebrand factor is synthesized by endothelium, megakaryocyte, liver, all of them. But maximum source of von Willebrand factor is by endothelium. This endothelium will have von Willebrand factor inside a storage body known as Weber palate body. So these are two platelet molecules I am showing you here. These are two platelet molecules I am showing you here. See this is a vessel lining. This is a endothelium vessel lining. Platelet is having two receptors on their surface, GP1B, glycoprotein 1B receptor on their surface, and another receptor is GP2B3A. GP2B3A. GP1B of the platelet will combine with von Willebrand factor, and this is known as adhesion. This is known as adhesion. So remember this concept, not mentioned in many books. What do you mean by adhesion? So remember this, adhesion means platelet attaches to the vessel wall. Platelet to wall is adhesion. How? Which receptor? This was the question in AIMS November 2013. How platelet will use which receptor to combine von Willebrand factor and to attach subendothelial collagen? So this was the question. So remember, GP1B will combine with von Willebrand factor. This is called adhesion. So platelet to wall adhesion, and platelet to platelet aggregation, platelet to platelet aggregation, platelet to wall adhesion. So this is called platelet aggregation. So what is this molecule? This is another MCQ. GP2B3A. GP1B is for von Willebrand factor. GP2B3A is for which molecule? This was another question, and they are usually fibrinogen. So fibrinogen is a molecule who will attach to GP2B3A of the platelets, and this is called platelet aggregation. So when we talk about platelet to platelet via this is called as platelet aggregation. Platelet aggregation. So adhesion and aggregation. When we are performing lab analysis, platelet aggregation, we will check by three type of substances which examiner uses in exam also, that is ADP, collagen and epinephrine. So we can remember platelet aggregation test. In short I am writing PAT, platelet aggregation test. Platelet aggregation test is done with the help of three substances ACE. So mnemonic is ACE inhibitor, same. ADP, collagen, epinephrine. So what is this? ADP, collagen and epinephrine. So ADP, collagen and epinephrine, they are used to check platelet aggregation defect. So lab investigation, when we are doing platelet aggregation with ADP, collagen and epinephrine, so we can interpret by two results. Either it is normal when all these are present, GP2B3A is present on the platelet surface, platelet aggregation test with ADP, collagen and epinephrine will be considered as normal, and if any of them is absent, then we will say that it is a abnormal or defective platelet aggregation. So this is a very simple, there is nothing new, but remember this one is tough, and this one I wanted to tell you, ristocetin addition test. So remember, name is ristocetin addition test. So ristocetin addition test. What is ristocetin addition test? It is used to check addition of the platelet to vessel wall. To understand this ristocetin addition test, we should know this concept. What is ristocetin? Ristocetin was a drug which is banned now. Only they are used inside the lab. And what is their use? If you add this ristocetin into blood sample, they will induce GP1B and von Willebrand factor. So GP1B and von Willebrand factor is induced by ristocetin drug. So when you add ristocetin to a blood sample, these two things are expressed, means both are present. So is it a normal or abnormal? Normal, and it's a normal. GP1B is present, von Willebrand factor is present, and such type of test is called as ristocetin addition test. So in exam they will ask you ristocetin addition test, shortly I am writing RAT. Ristocetin addition test, if both are present, will be considered as a positive or negative? Positive or negative? So when both are present, it is positive, means normal. So ristocetin addition test positive means normal. So this is the point where examiner will confuse us. So remember, it's not like a usual test. HIV positive means abnormal. Ristocetin addition positive, it's normal. How we will remember? By this concept. Ristocetin addition, when you add GP1B and von Willebrand factor, both will be induced. When it will be induced? When both are present. Then they are called as ristocetin addition positive, normal. So normal. But suppose any of them is absent, if suppose either this or this is absent, then when any of them is absent, we will say that ristocetin addition test is negative. Negative means abnormal. So this is how we have to keep this concept with our brain. When GP1B, von Willebrand factor both are present, ristocetin addition test will be positive, means normal. Both are present is normal. So it is ristocetin addition test positive. When any of them is absent, we will say that ristocetin addition test is negative or abnormal. So this is how we have to approach case. So now let us see what are the disorders associated with GP1B deficiency. Another short MCQ, very simple MCQ. GP1B, if it is absent from the platelet, what is the name of this disorder? So GP1B deficiency is known as So remember, if examiner is asking ki GP1B is deficient, so what is this? Platelet adhesion disorder. So this is number 1 platelet adhesion disorder known as Bernard-Sallier disease. So this is Bernard-Sallier disease, which is a platelet adhesion disorder. So it is adhesion defect. Bernard-Sallier, GP1B is deficient. So this is Bernard-Sallier disease, platelet adhesion disorder. Remember, these are autosomal recessive. Autosomal recessive disorder. Number 1 point. Number 2, if you look at this patient, Bernard-Sallier disease, if you observe their platelets will be large or small. So they had asked once in All India AIMS exam. So here remember, Bernard-Sallier disease, platelets are large. Platelets are large. Why I am saying like this? Because this was the question. This was the question in All India exam, where you will find small platelets on peripheral blood. Where you will see a small platelet in peripheral blood, make a note of this. It's a Wiskott-Aldrich syndrome. Wiskott-Aldrich syndrome. Wiskott-Aldrich syndrome, a small platelet we will see. This was the question in All India AIMS exam long back. Small platelets are also seen in Glanzmann's thrombosthenia. Glanzmann's thrombosthenia. So just remember this point also. So platelets are large in case of GP1B deficiency, means Bernard-Sallier disease. So Bernard-Sallier disease, autosomal recessive, platelets are large, bleeding time will be prolonged, but platelet count will be slightly or mild decrease platelet count. So this is one exception. So number 1 platelet adhesion disorder. Number 1 platelet adhesion disorder is Bernard-Sallier disease. So Bernard-Sallier disease, if you check their lab analysis, lab finding, what you will see that bleeding time is prolonged. PT and PTT, what will happen to PT and PTT? Is it a clot factor deficiency? No, not at all. It's a platelet disorder. So in case of Bernard-Sallier disease, since clot factors are normal, so PT and PTT both will be normal. And if you look at this platelet adhesion test with ADP, collagen and epinephrine, what will happen to them? Normal or defective? So just think about it. This is the platelet where only GP1B is deficient. GP2B is normal. GP2B is normal. If GP2B is normal, platelet aggregation test with ADP, collagen and epinephrine will be also normal. So this will be normal. Platelet aggregation test will be normal. But when we talk about ristostatin adhesion test, what it will be? Positive or negative? Positive or negative? Positive means normal, negative means abnormal. So here GP1B is absent. So when you add ristostatin, there will be no adhesion, negative. So ristostatin adhesion test is negative or abnormal. So like this we have to remember. So this is a lab finding of GP1B or Bernard-Sallier disease. Number 1, platelet adhesion disorder. Number 2 platelet adhesion disorder is a von Willebrand disease. Von Willebrand disease. Von Willebrand disease, they are having 20 subtypes. And here starts question number 1. Out of these 20 subtypes, which is the most common? Which is the most common type of von Willebrand disease? Type 1 is most common. So remember, type 1 is most common type of von Willebrand disease. So type 1 is most common. Another question they ask, what is the most common type pattern of inheritance? So inheritance also all type. Inheritance also we can see all type of inheritance. But which is most common? Autosomal dominant. So most common type is autosomal dominant inheritance pattern. Von Willebrand disease, one concept we should understand that What is important function of von Willebrand factor? Von Willebrand factor, their most important function is to provide stability to factor 8. So what is von Willebrand factor? They stabilize. So remember, they will stabilize factor 8. So this is the function of von Willebrand factor. They stabilize factor 8 in our blood. So inside the blood they stabilize factor 8. So in case of von Willebrand disease, what will be the lab finding? Now you will see what is the lab test. So bleeding time will be prolonged. PT and PTT, what you will see? Prothrombin time will be normal, and here comes the twist. See, this is a bleeding disorder which is a platelet disorder, but in this platelet disorder what we will expect? That platelet prothrombin time is normal, but PTT, because von Willebrand factor is deficient, so as a result factor 8 will be inactivated soon. So patient will behave like a hemophilia A. What I said? Like a hemophilia A, factor 8 deficiency. So because of that deficiency, PTT will be prolonged in this patient. So PTT will be prolonged in case of von Willebrand disease. PT normal, PTT prolonged. Platelet aggregation test with ADP, collagen and epinephrine will be normal, because GP2B3A is normal. And ristocetin addition test, if von Willebrand factor, if you add ristocetin, von Willebrand factor is absent, negative. So ristocetin addition test, negative. Negative means abnormal. So ristocetin addition test is negative or abnormal. So this is a very old pattern of AIMS, which they used to ask like this, there is a bleeding disorder case, lab profile is bleeding time prolonged, PT-PTT normal, platelet aggregation with ADP, collagen, epinephrine is normal, ristocetin addition test negative or abnormal. So they will not write abnormal, they will just write ristocetin addition test negative. So always remember, negative does not rule out. Here negative means abnormal. So this is the point I wanted to tell you. So this is how examiner will keep two similar questions. Now you can see both are platelet addition disorders, and only one sharp difference is there in these two. And what is that? What is that sharp difference? That is a factor 8 deficiency. And because of this, PTT will be prolonged here, and in this case PTT was normal here. So this is only difference between these two. So be careful, be cautious for this question. When examiners say bleeding time is prolonged, and this is the lab parameter of a platelet disorder, so what is your diagnosis? So when he is talking like this, look for the PTT value. When PTT is prolonged, it's a case of von Willebrand disease. PTT is normal, it's a case of Bernard-Sallier disease. So this point just wanted to tell you. So here what we have to focus is ristocetin addition test. When we are performing ristocetin addition test, negative means one of the factor is absent, either GP1B or von Willebrand factor. Means negative, they are not present. If they are not present, it's abnormal, negative. So this point we should remember. What is thrombocythemia? All India 1996, and they have repeated this question DNB exam previous year. What do you mean by thrombocythemia? Thrombocythemia. So remember, thrombocythemia means platelet aggregation defect. Thrombocythemia means platelet aggregation defect. And what is the name of this disorder? That is called Glanzmann's thrombocythemia. So see, this examiner has taken this thrombocythemia and they have silenced this Glanzmann's. So Glanzmann's thrombocythemia is platelet aggregation defect, which receptor of platelet is damaged or mutant here. So it is because of GP2B3A mutation or defect. So GP2B3A mutation will give rise to Glanzmann's thrombocythemia, which is an aggregation disorder. Again, they are autosomal recessive disorder. As we have discussed earlier, कि platelet will be small on peripheral blood. So micro platelets or micro megakaryocytes are seen in Glanzmann's thrombocythemia. And in this patient, if you observe lab analysis, features are like this. Bleeding time will be prolonged. PT and PTT will be normal because no clot factor deficiency. Ristocetin adhesion test. See this. It's a platelet aggregation disorder. So 2B3A is absent. GP1B is normal. If GP1B is normal, then adhesion will be normal. If adhesion is normal, so ristocetin adhesion test will be positive or negative? Positive. Because GP1B is present, 1 Willebrand factor is present, so ristocetin adhesion test will be positive or normal. So never think it is a positive means abnormal. So that is why I described it. It is not like other tests where positive means abnormal. Here it is reverse. Positive means both are present, GP1B, 1 Willebrand factor, and it is a normal case. So ristocetin adhesion test is normal means positive, whereas platelet aggregation test with ADP, collagen and epinephrine will be defective. So this is the point we have to remember. So these are important points we have to remember here. Now I will discuss one AIMS question. To close this coagulation disorder, there was a question in AIMS November 2011. And All India exam also they had asked question ki if a isolated prolongation of PTT is there, isolated prolongation of PTT is there.